And thank you, everyone. We're going to get started with our next session of our Boosters and Beyond series. Again, this series has been focusing on various topics related to readmissions. And today we have Marguerite McLaughlin going to be talking to us about dementia care as it relates to readmissions. So if you're not familiar with who we are the IPRO QIN-QIO. IPRO holds the federally funded Medicare QIO contract as shown here for the 12 regions under CMS. IPRO specifically covers New York, New Jersey, and Ohio. Health-centric advisors helped cover Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And then Clarent covers the Maryland, Delaware, and District of Columbia sections as well. So if anyone asks you if you're familiar with who IPRO is, you say yes. We are 3 companies together working under the IPRO QIN-QIO. So we always start our series sessions with some updates related to vaccinations. Particularly, it's been about COVID, but we also want to keep an update as we're in the flu season. So right now, we're actually continuing to see increased activity related to the flu, which has been dominated by the H3N2 strain, being closely followed by the H1N1. So far, there's already been 1.6 million illnesses, 13,000 hospitalizations, 730 deaths. And rates actually continue to be higher at this time than for the past decade. So interesting to note is the flu shot this year that they're giving out has a good match for the strains that we're seeing. So we want to definitely encourage as many folks to continue to get the flu vaccination because it's definitely going to be helpful as we continue to head into this season. As far as some COVID vaccine booster updates, boosters are up to 26.3 million, rather, up from 22.8. So we are seeing a continued increase in folks getting the bivalent booster, which is great to see, and we need to continue to push that. Hospitalizations is up actually from last week as well. It's a small uptick from 0.4%, now we're to 0.7, with a 7-day average of around 3,304, up from 3,282. With the latest variants, the BQ 1.1 strain had actually bumped up to being the second most dominant strain of COVID, up from the third place. And preliminary data from Pfizer so far is showing a robust increase in antibody levels for both the BA4 and BA5, as well as the original strains. So the bivalent boosters are working. They're showing great antibody levels. So I know there's a lot of COVID fatigue. Everyone's tired of hearing about it. Everyone's tired of getting stuck with needles. But this booster really is effective, and the numbers are showing for it. And with that, I'll pass it over to Marguerite.
Thank you so much, Josh, and thanks for the update, because that's always helpful to kind of keep our eye on the prize. It's also good to hear that the vaccination for flu is really pretty well aligned with the actual strain, so that's great. I'm excited to talk with you this morning, this afternoon, about this particular topic, having worked both in long-term care and also at the Alzheimer's Association for a long time. And I think for many of us, this was kind of the bane of our existence, was the relationship between rehospitalizations and folks who have dementia. And I want to share with you in this session a little bit about some work that we did up in Maine during the National Dementia Partnership, and share with you some of the ways that we actually went about helping to reduce readmissions from a real life perspective, taking a holistic approach, kind of broad. And I think this warrants, this is kind of the Reader's Digest version, but I want to be sure that you have some resources. And so Josh in a little bit is going to put some different links in the chat, just so that you have a place to go when we're done and you can kind of look some of the resources over. I also want to share with you some of the care practices and a model that we put together and piloted during our time up in Maine, bringing together this particular project and program. So I think you'll appreciate. So next slide, just kind of putting things in perspective. Readmissions require transitional care, as you know, and that's basically described as a set of actions designed to ensure the coordination and continuity of healthcare as patients transfer between different locations or different levels of care, sometimes even in your own setting. I became really painfully a part of this when I had the chance to work in New Orleans after Hurricane Katrina and deal with a lot of folks who had experienced some transfer trauma. Talk a little bit about that in a minute. So readmissions confound this whole transition kind of conversation enormously for any elder, but for people with dementia, it becomes in so many ways a nightmare. And next slide, please. So some of the challenges that happen along the way for our folks who transfer, whether it's within the nursing home from maybe a regular unit to like a memory care unit, or folks who transfer from home into our nursing home, or the bigger one from the nursing home to the hospital, which is one that I'm going to focus on quite a bit. And then certainly from the hospital back to the nursing home. All of those create their own unique trauma. But I think there are some strategies that we can put in place so that any of those readmissions are limited along the way. Another challenge that we find is institutional care, and that's that one size fits all model. Sometimes for our folks at the hospital who have less opportunity for a lot of great training in dementia care, I think sometimes that the hospital tends to be a little bit more one size fits all, whereas in our settings in nursing homes, we're able to really individualize the care in a very unique way so that we can target at specific ways to support our folks with dementia. Needless to say, on a bigger scale, the fragmented healthcare system kind of contributes to the difficulties for our folks with dementia, and also some of the communication processes that get kind of weak and sometimes get left off the playing field as we transfer folks between our settings. Next slide, Josh. Just to put the whole thing in perspective, about 25% of older adults admitted to hospitals have dementia and are at increased risk for serious problems like hospital falls and delirium. So you can see where just by virtue of having dementia, it already puts you at a disadvantage. Next slide, Josh. So some of the things that we know from research is that 17 of the top 30 most common health conditions, everything from diabetes to pneumonia, older adults with dementia were more likely to be readmitted to the hospital than people without dementia. And a lot of times people see that risk because difficulties following directions, particularly when it comes to meds and follow-up visits, more appropriate for home care. And but also, even in our settings in long-term care, people with dementia may be less able to express their symptoms, express them in a timely way. A lot of times not until things have gotten kind of off the rails, so to speak. And then also special discharge planning for people with dementia isn't available in most hospitals. And a lot of times the discharge process being so speedy often that a lot of information gets left behind. So that creates some of the risks that we're looking at. Next slide, Josh. Researchers talk about a very specific thing called geriatric syndrome. And this is one of the risks that relates specifically to our folks with dementia. So in the hospital with they're much more likely to encounter these adverse events, and they're kind of termed under this bucket of geriatric syndrome, which is falls and delirium and a loss of function that increases the length of stay, but also increases mortality. And so those kinds of things are the targeted areas that we're really trying to work within. But as you can see, there's a lot of contributing factors that lead to these, and especially as we think about them, sometimes it relates to the assessment and treatment, sometimes inappropriate interventions unrelated to those for our folks who have dementia, even discrimination and low staff levels right now, as we know, lack of staff training, especially as we have a lot of folks maybe from agencies within our buildings who might not be able to, they don't have that, shall we say, je ne sais quoi when it comes to really taking good care of our folks with dementia. They're the ones who tend not to speak fluid Alzheimer's. And so all of those things contribute to this particular syndrome. Next slide, Josh. One other thing that often we don't talk about is a thing called iatrogenesis. And it's a Greek word, and iatrogenesis often means that it's harm that's brought about by healers, people like us with the best of intentions. It's an unintended outcome, and certainly, for instance, a great example was CMS in its had us as in its effort to keep COVID from spreading, had us isolate residents. But the unintended outcome of that was the effects that had on so many residents, particularly folks with dementia, that being isolated was not the best for them. And many suffered very significantly as a result of that. And so all of these things kind of play a very, very specific part. Less well recognized are potentially harmful influences of knowledge and values and beliefs. Some of the very values that we hold will sometimes play a part in that. I have a 96-year-old mom who doesn't have dementia, and but everybody greets her with like such remarkable surprise that she's 96 and can think on her own, and often don't even make an effort to speak with her first, because there's this assumption that she's old and she must have dementia, so therefore I'll speak with a family member. So sometimes those beliefs and attitudes are kind of tucked in there deep. So something to keep in mind is iatrogenesis and what part we're playing in the well-being of our residents along the way. Next slide. The Journal of Medicine went on to describe this pathway of harm that happens, and that there's this acute hospital admission, and because of some of the attitudes and some of the things that are happening, that people don't do an adequate assessment on folks, and you can kind of see how it leads to adverse events and turns into this cascading whole montage of difficult clinical problems that all happen, and the cycle gets repeated. And so this has become kind of like a known pathway in hospitals that people are trying to break. And so next slide, Josh, they have some suggestions, and they talk about how there's not a single solution for this, but what's needed is kind of like a multi-level, almost 7 levels of care, which is patient, task, staff, team, environment, the organization, and the institution, and focusing on those different elements. That might sound like a lot to swallow all in one bite, but the work that we did in Maine actually looked at those 7 different layers and actually kind of parlayed them into a way that nursing homes could consider and help to reduce readmissions. And so I'd like to walk you through that right now. Next slide. You'll see this is part of the main dementia care partnership, and a whole gang of folks, pharmacists, doctors, folks from the Alzheimer's Association, the QIO, nursing home providers, all got together to actually put together the best practices and try them out so that they could have a better sense of what it would do to take, one, to reduce antipsychotic drug use, but more importantly, to create an environment that was so therapeutic in its very foundation that it would actually help to reduce readmissions to hospitals. And as a result of the work, this is the website where you can go to find out more about this, and we certainly can help you. Josh and I have done a lot of work with this, and I'm happy to walk you through some of the various aspects of it. But in the next slide, what we did was, with the help of all of these folks, we put together a change package that has 8 key ideas. Can you switch that for me, Josh? Yep, next one. Great, this is perfect. And what we did was we actually, based on literature and also this pilot study that we did, we actually put together these 8 elements and asked nursing homes to work with us to see how they worked and to see if, in fact, they were actually critical elements in not only reducing antipsychotic drugs, but helping with the overall health and wellness of the population of folks who had dementia, and also reduce readmissions. I'll say them quickly. Just the first line of defense is number 1, a therapeutic environment, a data-driven dashboard, obvious and demonstrated competencies on behalf of the staff, hospital transition process, family education, a process for gradual dose reduction, and physician and medical director engagement. And excuse me, within each one of the elements, what we did was we actually experimented. And what we did was we actually put together a plan, an actual change package, change idea that the homes would adopt and try out over a course of a certain amount of time. And so let me walk you through some of those just to give you, I'll go quickly on some of them. The first line of defense was to kind of get everybody on board. Why is it less of a, why do we want to limit antipsychotic drugs where it's possible for our folks, off-label use of antipsychotic drugs? And so what we found were that when we got the whole place singing from the same choir sheet, so that the medical director, the director of nursing, and that even CNAs could tell why they could actually articulate why they were doing some of the things they were doing and using some of the approaches they were using, instead of using off-label antipsychotic drug use. And so that became a really important part of the story. So getting everybody on board, including families. The second one, next slide, you'll see talks about a therapeutic environment. And this one is where the real beauty of a holistic model comes into play. And some of the elements of that included making the place where people lived in its own right part of the therapy that was part of the ethos of that home. And so, yeah, it looked at things like how to, what are better colors and what does better lighting look like? But more importantly, what are some of the practices that staff need to adopt in order to be therapeutic in their care of all the residents? And so everything from staffing to ADLs, how they were performed, when they were performed, and creating an overall environment that was really comforting and peaceful in its own right. And even the activity program was changed in order to create a place where people went to for the day, almost like an in-house daycare program, so that people could feel like they were making a valuable contribution and had kind of like work and a place to go. And so even that became part of this therapeutic environment that was created in many of the organizations with whom we worked. The next one is a data-driven dashboard. That's number 3 of this really important package that these folks worked on. The data-driven dashboard actually uses Casper as its kind of point of origin and looks at some of the different people who were on antipsychotic drugs and use that data in order to really target the care. So trying to reduce falls, trying to reduce a lot of the other things that go along with antipsychotic drug use. The fourth element that we were talking about was obvious and demonstrated competencies on the next slide. And what we saw was special training that was devised especially so that staff would develop a special knack in understanding the needs of residents. And so it wasn't just a matter of anybody who is any warm body will do. It was about helping to develop people's skills so that they really had a knack. We used to call it speaking fluent Alzheimer's, because it really was something that we were trying to train for and get people to really wrap their arms around. The fifth one, and this is where I wanted to spend a little time, is hospital transition process. And so what we recognized was that the transition to the hospital often set many of the residents back months in their baseline. Even simple trips to the hospital became big events in the lives of those residents. And it took a long time to climb back out of the hole and get them back to a healthy place. And so in the pilot, what we actually did was we began to look at what would be some of the things that would really help to benefit the folks with dementia, and what are some of the practices that the staff could kind of embrace along the way. And so what we did was we helped folks to develop a BAT team, a bedside assessment team. And that was when any kind of change in conditions started being noticeable. A certain group of people were actually designated to go in and do a full assessment and put together what we call the 24-hour plan. And the 24-hour plan was a decision about the type of plan and care that we would use on that particular person, whether it was hydration and bed checks and all kinds of things that would allow us to make a decision whether or not to send the person to the hospital. The enormous number of times that we were able to preempt a hospitalization, because so often a really attentive staff, the CNAs who were given guidance about the things to be watching for through the BAT team, actually helped to preempt some of those hospital visits and some of that transfer trauma that goes along with it. Let me show you this next thing. One of the things that was developed by the team was a transition form. And so certainly there's plenty of information that goes out, but this transition form was really a way to help the hospitals to be able to recognize some of the person-centered approaches that some of the nursing homes had actually applied. And I wanted that the nursing home also wanted caregivers at the hospital to be able to understand what some of the behaviors might look like and how to help mitigate some of those, what to do, what pain in that person might look like, and what are some of the things that could happen. And so you could see this was actually printed on a piece of purple paper and actually went out with the resident, so that to kind of make an attempt to at least get useful information about how to provide person-centered care, very specific individualized care for that resident. And so that became one of the interventions that was mildly successful. Where it was applied, it was great, and where people were able to do some of that. So it was a wonderful thing. So for rehospitalizations, creating this kind of climate within which people are way attentive, know the residents really well, being able to use this particular sheet and having a BAT team where 3 interventions that really helped with that whole heading out to the hospital and readmissions and how to take care of folks along the way. So next slide is talks about family education. And in a similar way, we asked folks and piloted the decision guide, and that's at decisionguide.org. And that's Dr. Ruth Tappan and her team, part of the Interact team, who actually, we've mentioned it on our call several times, but helping families to understand how much care the nursing home folks were able to actually do, and that lots of times it didn't require going out to the hospital. And that became so important along the way, because we felt that it really helped families to get a better understanding of how strong the clinical care team at the nursing home actually was. And so that was kind of key for our work. And then the next was to actually look at a process for gradual dose reduction. I want to call to your attention that it's number 7 in the change package. And why is it number 7? And it's because we saw so many times that folks would go to do a GDR, but hadn't put a lot in place before they tried it. And as a result, what we saw frequently was that 2-3 weeks later, folks were back on antipsychotic drugs. And so just by putting some of the interventions in place ahead of time, particularly those that related to the therapeutic environment, making sure that people were gainfully active during the day, got good sleep, all of those kinds of things were actually key. And we asked people to put those in place before they did the GDR. Josh, anything you want to add?
No, I think you hit it right on the money. I think all too often when we're working on our quality measure to reduce antipsychotics, we look and see, oh, who could we maybe take the antipsychotic medications off of, and all too often we don't go this in depth of putting these systems in place, and then are surprised when they don't work when we take them off. And I think you really hit the nail on the head, is that we need these systems and processes in place before we even attempt the gradual dose reduction. Otherwise, it's most likely not going to be successful.
Yeah, thanks, Josh. Yeah, it's a big deal. And again, I can't emphasize enough, people kind of throw the word holistic approach or holistic around, but this whole topic, it really focuses on a full multi-team, multidisciplinary team, all being on the same page, all working together. And actually, so this is not a clinical topic. Readmissions and transfers to the hospital, it's not a clinical topic. It's a holistic topic that has to be approached with every department playing a part in making sure that you create the kind of healthy environment that's going to allow people to live really well with very few trips to the hospital. And the last one here is the physician and medical director engagement. And all that's really about is a lot of times we hear complaints from folks, and folks have a great longing to have a really solid medical director who's there, on the scene, playing an active part, who's really part of QAPI, more than a few times a year, but actually on board with this kind of philosophy and on board with all kinds of alternatives to using antipsychotic drugs, which is kind of like the portal to hospitalizations for lots of our residents. So all of those things said, I'm already at 12:29. So I'm going to stop here. And I know it's a lot to take in. Hope you'll take a few minutes to check out the resources, because personally, I saw some of these things in action, saw lots of the nursing homes who adopted one or more, or made an attempt to go through all 8. And it took a while, but just having them outlined for them, they were able to make great strides And on a side note, and we didn't have a way at the time to also study it, but there was a lot of staff satisfaction because people felt like they had a plan, and staff satisfaction leads to staff retention, and it makes a huge difference. So I love this form. I'm so glad it's in that packet on the website. I just direct you over to that partnership. And BAT stands for Bedside Assessment Team. And we also have a lot of great information on setting up a bedside assessment team because it's awesome when it's working. It's a multidisciplinary team. When you start to see a change of condition, they go in, they do the assessment, they put together the plan, and they all agree or disagree whether to send the person to the hospital, certainly with the doctor also. So, okay. I'm just looking through. Anything else, Josh, I missed?
No, I think you got it all. Does anyone have any questions for Margie while we're here? And I'm going to put my contact information into chat as well. If you're interested in learning more about the bedside assessment team, or want to talk about better dementia care in your buildings, happy to help support you as well.
Yeah, Josh and I are happy to jump on a call with any of you independently or with your teams. I'm happy to walk you through any of that.
Yeah. And thank you, Melanie, so much. There's actually also a link that she had just put into chat as well. We have an event coming up in December called New Day, and it's focused on nursing home education. It's a summit that we're going to run from 9 a.m. to 3 p.m. So it's going to be a full day event, a lot of education, a lot of opportunities to learn some new things on various different topics. So be sure to check out that link that Melanie put into chat, and we'd love for you to register and come join us.
One of our guest speakers is Dr. Laura Stratton, a senior director at the Alzheimer's Association. Transforming quality dementia care is going to be one of the topics. So very excited to hear her speak.
Sounds good.
All right. Last call for any other questions or comments. And if you get a second before you leave, just let us know if you found this session helpful.
Thanks, everybody.